Most physicians within a month figured out a couple of things that they didn't realize. One is telehealth really works. You can actually do telehealth effectively. You can actually take care of patients. You can continue to provide health care, and you can do it remotely. And the second thing they learned is those staff that were working in their offices, doing all that work in their offices, their staff actually can function pretty well remotely. Their staff can work from home. A lot of that back office services can be done remotely. Scheduling, registration, claims, billing, all that stuff can happen, and it doesn't have to be under your direct vision. And if it can happen remotely with your staff, well, then actually maybe it can happen remotely in a platform where not only do you not have to worry about people working from home, but somebody else can worry about the people who are working remotely.
What you just said naturally takes me to my next question is, what do you see as the future of GI post the pandemic?
Certainly we see that we're probably going to continue to do telehealth. 30-40% of our visits will probably stay at telehealth. It may take a little bit of lobbying with the payers and Medicare, although I think Seema Verma recently just said, we're definitely going to have telehealth after COVID. So Medicare certainly, she still feels it's an absolute necessity. Profitability of our surgery centers may lag. I'm not sure we'll ever get back to the same profitability, or at least not for a few years. I think some of the things that we will have to put in place, some of the provisions, some of the PPE, some of the scheduling modifications to clean rooms, things like that. I'm not sure we'll ever achieve the same profit margins unless we can get higher payment.
Don't you see more cases coming from the hospital to the surgery centers?
That is definitely, yeah. So hopefully, but that means in order to, our centers were relatively busy before. So does that mean we're going to have to expand our surgery centers with space and staff, open another room? Most groups probably have a backlog of 3 or 4 months of procedures. So how do we catch up? Assuming that the patients still want to come in, how do we catch up? At some point we'll have to start doing 6 days a week, but that means hiring extra staff. I think roughly half the ambulatory procedures in the country are still performed in hospital outpatient departments. So there's certainly quite a few patients that might shift to ASC locations. I think we'll get into more chronic care remote management. It was already starting to happen before COVID, but looking at how do we manage the epidemic of obesity and NASH and NAFL and weight management, that's more chronic disease management. Concerned that our clinical research may be more complicated, at least for a few more months, of getting patients enrolled into trials because of the number of visits. And we're trying to avoid all this face-to-face contact. That may require some changes in how sponsors want protocols to take place. And certainly the standard paper binders for clinical research, there needs to be some change to make those electronic. I've read most of your Scope Forward book, and there are aspects of it that almost predict the need to adapt to COVID. That you didn't know about COVID, but the whole concept of innovation and adapting that you have written about and talked to people about it's like, how did he know that we would have to actually meet and discuss and figure out how to adapt our workflow? I'm certainly very nervous about what I see in Florida and Arizona and Texas. The last thing I would like to see here is a second wave like that. I don't think we could. That would be a financial disaster if we had to close down again. So that I'm hoping we avoid that. I think most of my partners, certainly my older partners who are in the high-risk groups for COVID, the people who don't do as well when they get infections, most of them are going to wait for a vaccine before they really get comfortable. And that's probably going to be February or March of 2021.
Really a precarious time, and whichever way I look at it, like I read all the reports from clinical to economic. The thing that I come back to is that nobody really knows, and there are different estimates, and that keeps changing by the week. So yeah, the way I see it is like you go with the flow and you figure it as you go along. You have
Yeah.
this distant view, and you fold that future in, you work in that direction, but the situation can be very dynamic and it can change quite quickly.
Adapt or die, right? Adapt or die. And it's interesting, when we did our strategic planning, and some of the partners were very happy where we were, and their comment was, well, why do we need to change anything? We're doing so well.
Yeah.
Why don't we just do what we keep doing? And the consultant said, doing nothing is not strategy. Standing still is risky. Standing still is not a zero risk option. It's actually a very risky option. Stand still in the middle of a busy street. You're going to get run over. So you have to constantly adapt. That doesn't mean you get it right every time. You may sort of make a maneuver or make a change that doesn't work out. You need to measure all of the changes that you make and determine whether or not the adaptation is moving you in the right direction. One of the best talks I ever gave at one of the meetings was the 10 things I wish I hadn't done. And it was hard to get to 10. I had to cut down from a list of 15 or 20 to get to the top 10 that I wish I had not done.
Uh-huh.
So, but on the other hand, I probably have that list and longer of the things I think we did correctly. So far, so good.
Dr. Weinstein, reflecting back on your own career and going back all the way when you were an early career gastroenterologist, I'm sure you had certain visions about healthcare and where GI would be at this point of time. And so, where does that stand based on what all you're seeing going on right now?
Technologically, obviously, what we're able to do technologically in healthcare, amazing. But then you see it, then you get a pandemic, and you realize how fragile things are. When I first went into practice, I came out of my fellowship, and I joined 2 gastroenterologists. They went from a group of 2 to a group of 3. But they had close friends who are, if I mention names, I'll mention some names, and everybody knew those. So one of my partners trained with Gene Overholt. One of them was close friends with Jim Frakes. One knew, I was able to learn from the giants because my 2 older partners made me go spend time with these soothsayers. Gene Overholt, the father of endoscopy, and Jim Frakes, who really was a business, a healthcare business savant. And I went up to Minneapolis to go meet the leadership of the Minnesota GI group, and looking at how they saw a gastroenterologist, and then just paying attention to what was happening in the Mid-Atlantic area, which was a lot of mergers of insurance companies and mergers of hospitals. So I think within a few years of going into practice, I already sort of had a notion that the only way we're going to be successful is we have to be more relevant. We need to have our own endoscopy center. And I, with my 2 partners' support, I built an endoscopy center in 1985, which was very early, pretty much following almost following the floor plan of what Gene Overholt had built in Knoxville.
Mhm.
So lucky to do that. I don't think I could have foreseen the need to get this big, but along the way, that seemed to be an obvious change. And it's not just it's not just GI practice; it's healthcare delivery, hospital systems. One of my partners, I have a partner who likes to say that when he grew up, his father told him he had 2 ears and 1 mouth, that he should listen twice as often as he speaks. So the idea is to go listen to people who have been through the trenches, have figured out the good parts and the bad parts, follow the good parts, avoid the bad parts, and pick and choose. So I feel very fortunate to have been around a lot of those people over a 30-plus year career. It's been a privilege to lead and hopefully lead things a little better. I have 3 sons, and I sort of pass on with some wisdom. I say, you know, as you get along, as you go through life, none of them went into healthcare, but the advice I gave them was, you know, as you go through life, try and pick up after yourself. Don't leave a mess, and try and leave the world a little better off than you found it. You know, that's the goal.
What advice do you have for early stage gastroenterologists?
Yeah, I love talking to young fellows. Maybe it's because my kids are sort of around that same age, and I think if you're a fellow and you're looking for a career that you get to choose your career, you get to choose what you're interested in, and when you go talk to a group, probably the first thing you should ask is, you know, first you should say is what you're interested in, what kind of career you sort of see for yourself. Do you want to be an interventionalist? Do you want to do IBD? Do you want to do liver? Do you want to do, you know, esophagus work? What's your passion? Figure out what your passion is, and then if you're talking to a group, is your ability to continue to follow your passion fit with the strategic goals of the practice that you're talking with? The question you shouldn't ask first is, how much are you going to pay me? That's not the first question to ask. First, explain what you love to do and why you want to do that, and that's what I would do. I think independent practice has the best of both worlds now. I think independent practice allows, with the advent of larger groups, it allows the ability of somebody to subspecialize, to follow a passion within a big group, and to be fully supported in doing that. So if you need different equipment, if you want a different schedule to accommodate that kind of care, patient care, then it's probably easier to get that done in a bigger group than it is in an academic center. You know, they're coming out of their fellowship, they've got 30 years to practice. Again, you know, you have to find something you like to do so that you can get up every morning and go do what you like to do. Because if you like what you're getting up to do, it doesn't feel like work.
Dr. Weinstein, I want to get to a final question and reflect on that a little bit, and it is to do with social disparity in healthcare. Now, whichever way you slice healthcare, it's quite apparent, and all these years and probably decades, we've probably pushed this under the rug, and it's come to the fore now. So I wanted to reflect that with you a little bit and get your thoughts.
Yeah, well, I certainly always considered myself very socially conscious, but it's obviously been made apparent more so that as much as I thought I was, we weren't. That we got to a situation that, and how we got there, I'm not exactly sure, but I know that when I looked at our I went on our website and looked at all the photographs of all the physicians in Capital Digestive Care, and we seem pretty diverse until you start sort of figuring out the ratios and the numbers, and you go, how did we only end up with, such a small percentage of African American partners in Washington, D.C.? This doesn't make any sense. And I'm not sure how we ended up there. We did, and I don't feel particularly good about it. I mean, we have a lot of women. We have a lot of women partners, and there's certainly an obvious recognition that in this community, Washington, D.C. community, that the healthcare disparities led to some very bad consequences for COVID. And that's the thing. I think COVID, George Floyd aside, I think COVID really increased our awareness of just how much healthcare disparities can affect health outcomes. Because it's very clear that the percentage of deaths is so much higher amongst the communities who don't have accessible health care, who have comorbid conditions that are poorly managed, obese, hypertension, their healthcare disparities, their inability to access healthcare contributed to their deaths. And their inability to access healthcare has to be on all of us. We may not be able to fix the financing situation, Medicare, Medicaid, coverage, fair payment, but that doesn't mean we should ignore the fact that these healthcare disparities exist, and that if we care about our communities, that we need to provide that care. I'm on the AGA governing board right now, and there's certainly a recognition. I think everybody has been, light went off and went, how did we end up here? This is terrible. This was unintended to end up at this situation. And we all want to do something. We all want to make it better because we see the problems. But I think the first thing is we need to understand why it happened. What is it? And one of the things I know in gastroenterology is for whatever reason, unintended bias, unintentional bias, or whatever, but the African American contingent in GI's fellowship is 25% of what it should be based upon the population distribution. If 18% of the population is African American and another 15-18% is Hispanic, Latino, then how come the fellows are not equally distributed that way as well? And they're not. It's terrible. It's 10% of GI fellows are ethnically diverse. And we need to study that. We need to figure out why that happened, and we need to do something to fix it. And it may take a generation. It may take a generation, but if we don't start down that road, we're never going to get there.
Yeah, no, I'm so glad that you're recognizing that at an industry level. And now, what needs to happen? That is not happening. I also, not just from the physician disparity standpoint, but also the patient population, right? A lot of the problems that we see in healthcare actually don't originate in healthcare. They go back to the community. So it's higher up it's more upstream. But then insurances don't pay for going back and fixing problems upstream. And here's where we are. We've created a system that pays for certain things and doesn't pay for preventing those things. So what must happen if you have to freely reflect on ending this?
There's no doubt we have to go upstream, and obviously we're a big group in the Mid-Atlantic and the Washington D.C. metropolitan area. I'm not saying that I have any ability to fix the problems in the country, but I live in this community. I'm a neighbor in this community. I'm an employer in this community, and there are things that I can do for my employees, the children of my employees, the communities of my employees. and that I may not be able to fix the whole region, but I can start fixing what I can actually affect. I have to go upstream. We talked about providing internships for students, for high school students, for college students to spend time in our practice, from not from all over the country, but just locally, just from the local high schools, the local colleges. And we're going to have a paid summer internship, and we're going to try and increase the interest in healthcare and do things to promote healthier lifestyles in our community. If everybody would look just in their own communities, if everybody did that, there would be a huge change.
Mm-hmm.
So I don't have a solution for the whole country. I don't have the solution for Maryland, but I'm going to do what we've already decided. We're going to do what we can do, at least in the community that we can touch.
Excellent. Thank you very much, Dr. Weinstein. Was there anything else that you wanted to talk about?
Love talking to you. Love listening to you. Love to keep hearing about innovation and things that are on the horizon. New technologies, stuff like that will make it easier for physicians to provide healthcare. So thank you for all you do.
Thank you so much for saying that. I really enjoyed our conversation, and I'm sure people who are watching this will also do.
I hope so.
There were plenty of insights here. Thank you so much, Dr. Weinstein.
You're welcome.